Hello, this is Carolina Brooks speaking once again. In this section, we'll be going over different medicinal therapies targeting bacterial, viral, fungal, and parasitic infections. I'll tell you right now that this is a very high-yield section, both for Step 1 and beyond on the wards. However, this is also traditionally a very hard section for students because it involves a lot of memorization. I'll also tell you that I often memorize this kind of information and then forget it almost immediately after the exam. So this is the kind of thing that you'll probably have to learn over and over again. What I'm going to try to help you do is organize the information, but at the end of the day, cold memorization for this will serve you the best. I'm going to use this slide as a starting point to go through all of the antibiotics. Antimicrobials target bacteria through various mechanisms of action, so I'm going to go through all of these mechanisms of action one by one. Our first group acts on the bacterial cell wall. This includes three major groups of antibiotics, namely beta-lactams, vancomycin, and bacitracin. Looking first at beta-lactams, they include the original penicillin, aminopenicillins, carboxypenicillins, cephalosporins, monobactams, and carbapenems. Okay, so don't panic if all of those words that I just mentioned sound like a foreign language to you. We're going to go over all of those in a second. In general, all beta-lactams work by inhibiting peptidoglycan or PDG cross-linking. As for vancomycin and bacitracin, which actually isn't a beta-lactam, they also act on the bacterial cell wall, but they work instead by blocking PDG synthesis, as opposed to cross-linking in the case of beta-lactams. Next, we're going to talk about antibiotics that target protein synthesis. These include aminoglycosides and tetracyclines. They both target the 30S ribosomal subunit. There is a long list of antibiotics which target the 50S ribosomal subunit. These include the macrolides, chloramphenicol, clindamycin, linezolid, and the streptogramins, quinupristin, and delfapristin. Next, we have the antibiotics which target cell metabolism. This group includes the sulfonamides and trimethoprim. They both inhibit folic acid synthesis. Now, do you remember what metabolic process folic acid is essential for? That's right. If you go back to the biochemistry section, they are important for nucleotide synthesis, and therefore, as a result, inhibition of folic acid synthesis will block DNA synthesis. Lastly, we have the antibiotics that target DNA synthesis. This includes the fluoroquinolones, which block DNA topoisomerases, and metronidazole, which damages DNA. Rifampin is an antimicrobacterial agent which blocks mRNA synthesis. Okay, so we've gone over the general picture of antimicrobial therapy. Let's start going over each of these one by one. So first we're going to start off with a group that targets the bacterial cell wall. Now I'll tell you right now that there is a lot of information we're going to go over in the next few slides. I'm going to go over this step by step, and I'm going to try to be as clear as possible on this quite informative topic. We'll start off with the beta-lactams. Now this is quite a long list of beta-lactams, but we'll go through all of these in this list. As the title of this slide suggests, we'll start off with penicillin. Penicillin is basically the prototypical beta-lactam antibiotic. On the next slide, I'm going to show you an animation that illustrates how penicillin works. Take a moment to look at it, and then I'll discuss it in a second. Okay, so that was a very clear animation that's trying to illustrate to you the principle of how penicillin works. As you can see, a PBP or penicillin binding protein was used to make this cross-linking. In the case of penicillin, it blocks the transpeptidase cross-linking of the cell wall and activates autolytic enzymes. In other words, it basically stops the cross-linking of peptidoglycan proteins. So going back to the information, let's discuss what penicillin is useful for. It is effective against gram-positive organisms and spirochetes. Now, do you remember what sexually transmitted disease penicillin is first-line treatment for? Yep, you are absolutely right. It is syphilis. You can help yourself remember its efficacy against syphilis from the infamous Tuskegee syphilis study. It is also the drug of choice against Neisseria meningitidis, which is a gram-negative coccus. Here is the chemical structure of penicillin. You're probably groaning right now thanks to PTSD obtained from your undergraduate orgo course. Unfortunately for you, I'm a chemistry major from undergrad, and so I love to see these things, but I actually have a reason to show you this. My reason is because I actually think it'll be helpful for you. Penicillin has a beta-lactam ring, which I've highlighted here. The R structure, which you can see here, is the variable group. Bacteria that express penicillinase are resistant to penicillin G, an unfortunate emerging trend that prevents the routine use of penicillin G in many clinical settings. Penicillinase is one of a class of enzymes called beta-lactamases, a term which I'm going to use for the rest of this section. Adverse effects to penicillin are classically hypersensitivity reactions, which can range from a rash to anaphylaxis and induction of hemolytic anemia. Because penicillin is a beta-lactam, beta-lactamases, aka enzymes that degrade the chemical structure of the antibiotic, are a common source of resistance. Next we have the aminopenicillins. As you can see here from these chemical structures, aminopenicillin differs from penicillin in the R group portion of the molecule with the addition of an amino or NH2 group, as I've emphasized on the slide. Remember that penicillin in general covers gram-positive organisms. The aminopenicillins also share penicillin's mechanism of action, but have broader spectrum coverage and have greater gram-negative coverage. For example, they are effective against UTIs caused by E. coli and respiratory infections caused by H. influenza. In addition, they are effective against beta-lactamase producing bacteria when combined with clavulanic acid, which is a beta-lactamase inhibitor. I'm going to explain what these beta-lactamase inhibitors are in a second, so don't worry if you're not sure what I'm talking about. These are electron micrographs of Listeria on the left and E. coli on the right. Aminopenicillins are used for gram-positive bacteria and gram-negative rods. The mnemonic that I've written on the screen for you, ampicillin or amoxicillin helps kill enterococci, is helpful in remembering the organisms against which these antibiotics are effective. So I've written out them for you. Namely, they are Haemophilus influenza, E. coli, Listeria, Proteus mirabilis, Salmonella, Shigella, and of course, enterococci. When used without beta-lactamase inhibitors, beta-lactamases will cleave the beta-lactam ring, which is its mechanism of resistance. Now, I have a question for you. Do you remember that you can get a rash when you treat a virus with ampicillin? Do you know what virus that is? Yep, you're right. It's infectious mononucleosis, which is caused by the EBV virus. Let's be clear exactly why this happens. So, a sore throat is often a concern for streptococcal pharyngitis that is then treated with antibiotics. Later, a positive monospot test would diagnose infectious mono and not the strep pharyngitis you were initially treating for. Another side effect with amoxicillin and ampicillin is that you can develop C. diff colitis with ampicillin. Although you could get C. diff colitis with any antibiotic, it has a very common association with ampicillin, which they love to test on the boards. Okay, so next we're going to talk about the penicillinase-resistant penicillins. I mentioned just a few moments ago that penicillinase is part of the beta-lactamases. So basically, these are antibiotics that are resistant to the beta-lactamases. Here is a picture of penicillin again. The way they achieve this beta-lactamase resistance is because of the bulkier R group, which was that variable group you saw on the end of the penicillin chemical structure and which I've highlighted here. These antibiotics have the same mechanism of action as penicillin. Bacteria develop resistance to these antibiotics due to a mutation in the gene that encodes their penicillin binding proteins, or PBPs. This results in a PBP with a reduced binding affinity for methicillin, oxacillin, and these other antibiotics. Methicillin is the original drug in this class. However, methicillin is no longer used since it causes the serious side effect of interstitial nephritis. However, the names you'll hear, such as MSSA or MRSA, refer to methicillin, this original drug. As a group, these antibiotics have utility against Staph aureus, also known as methicillin-sensitive Staph aureus. However, it should be emphasized that bacterial resistance to even these modified antibiotics warrants consideration of alternative antibiotics when treating resistant strains. MRSA, for example, demonstrates an altered penicillin-binding protein site and cannot be treated with penicillins or similar antibiotics. I've written out a rhyming mnemonic for you. NAF is for staph, to help you remember that nafcillin is used for Staph aureus, specifically methicillin-sensitive staph or MSSA. In the case of methicillin-sensitive Staph aureus, do you think nafcillin or an alternative drug such as vancomycin, which is actually the drug used against MRSA, is a better drug? You may actually be surprised, but in the case of MSSA, you want to use nafcillin. The principle with these antibiotics is to use the antibiotic best designed to target that bacteria, and in the case of MSSA, nafcillin is most effective. You would use vancomycin only if you suspected MRSA. Like penicillin, adverse reactions of beta-lactamase-resistant penicillin derivatives include hypersensitivity and, as mentioned, specific to methicillin, interstitial nephritis, which is the reason why methicillin is no longer used. Great! Time for a flash quiz. You should be able to answer this based on the question we just did. For primary syphilis, you would use which antibiotic as treatment? What about for MSSA? Yep, for syphilis, you would use penicillin, whereas for MSSA, you would use nafcillin. Remember that for MRSA, nafcillin would be ineffective. Methicillin, for which methicillin-sensitive Staph aureus or MSSA is used, is not used clinically due to its side effect of interstitial nephritis. Next we have the anti-pseudomonals. These antibiotics have the same mechanism as penicillin, but with an extended spectrum. They are considered anti-pseudomonals for their activity against these particularly devastating bacteria. They are also used with beta-lactamase inhibitors, which I mentioned before and which I'll talk about next. So, beta-lactamase inhibitors. We've already mentioned clavulanic acid, which is used with aminopenicillins to help overcome beta-lactamases. Others are sulbactam and tazobactam. Remember, this cast of beta-lactamase inhibitors, which is the mnemonic for clavulanic acid, sulbactam, and tazobactam. You don't actually need to know which beta-lactamase inhibitor is used with which specific penicillin, but know these names so that you know that it is a beta-lactamase inhibitor when it is mentioned. Next we have the cephalosporins. These are beta-lactam drugs that inhibit cell wall synthesis. Like penicillins, they exhibit bactericidal activity against bacteria, but are less susceptible to penicillinase. They are, however, susceptible to cephalosporinases, which are another class of the beta-lactamase enzymes. As you can see, there's always something else that they will be resistant to. The cephalosporins are grouped into 5 generations, each with different characteristic activity against bacteria. The way I broadly think about the cephalosporins is that first generation has mainly gram-positive coverage, and as you go up the generations, gram-positive coverage decreases, while gram-negative coverage increases. I will point out, however, that there are exceptions to this rule, because 4th generation cephalosporins have more gram-positive coverage than the 3rd generation. But let's now go through all of these generations. A way to remember first generation cephalosporins is that it's the only generation where the drugs have a pH in their name. The only exception is the one that I've written here, cefazolin, and if you pronounce it as cefazolin, you remember that the fact it's a first generation cephalosporin won't phase you. Get it? Cefazolin, it won't phase you that it's a first generation cephalosporin. Again, first-generation cephalosporins affect gram-positive cocci, as well as Proteus, E. coli, and Klebsiella. PEC, which I've written on the screen for you, is a mnemonic to help you remember these extra organisms, namely Proteus, E. coli, and Klebsiella. Second-generation cephalosporins have some fur and fox in their names. Examples are cefoxitin and cefuroxime. They are effective against the same bugs as first-generation cephalosporins, plus Haemophilus, Enterobacter, Neisseria, and Serratia. The hen-pex mnemonic is a way that you can help remember these organisms. Broadly, the second-generation cephs will cover respiratory organisms as well as anaerobes. Third-generation cephalosporins have a T in their name, such as ceftriaxone, cefotaxime, and ceftazidime. They are used to treat resistant gram-negative infections. Ceftazidime, of note, is the only third-generation cephalosporin that is used against Pseudomonas. Do you remember which bugs ceftriaxone is used against? That's right, it's the Neisseria bugs, namely Neisseria meningitidis and Neisseria gonorrhea. Remember that you treat a patient with meningitis empirically with ceftriaxone and vancomycin, which is the antibiotic we'll get to in a second, and you also want to cover chlamydia too when a patient has gonorrhea. What were the drugs to cover chlamydia? Yes, you're right. Azithromycin, which is a macrolide, and doxycycline, which is a tetracycline, which are antibiotics we'll talk about in a second. Cefepime is a fourth-generation cephalosporin with increased activity against Pseudomonas and gram-positive organisms. Our last generation is a fifth-generation ceph, of which there is only one member, ceftaroline. Think of ceftaroline as ceftriaxone plus MRSA, namely that it covers the same organisms as does ceftriaxone with the addition of MRSA. I've written this out for you to help you remember. Ceftaroline equals ceftriaxone plus MRSA. It, however, unlike cefepime, will not cover Pseudomonas. I've written out the distinction of Pseudomonas for you on the screen. Note that there is a 5 to 10% cross-reactivity between cephalosporins and penicillins, so cephalosporins should be used with caution in patients who report an allergy to penicillins. They can also exacerbate the nephrotoxicity that is associated with aminoglycosides. Again, time for a flash quiz. So, which two cephalosporins have activity against Pseudomonas? You're right, ceftazidime and cefepime.